Good morning everybody. Today we will discuss hemophilia, ITP, HSP, bleeding disorders. So, congenital bleeding disorders are of two types: coagulation factor deficiencies and platelet disorders. Coagulation factor deficiency include von Willebrand disease, hemophilia A which is factor 8 deficiency, hemophilia B which is factor 9 deficiency, congenital A fibrinogenemia, factor 13 deficiency and other factor deficiencies. Platelet thrombocytopenia which is Wiskott-Eldridge syndrome, congenital A megakaryocytic thrombocytopenia, and platelet function defects like Bernard-Soulier syndrome, Glanzmann thrombocythemia, von Willebrand disease. So, here von Willebrand disease comes in both platelet group and von Willebrand disease, this coagulation factor deficiency group. So, approach to a patient with bleeding disorder: first we should see the age. If younger age, then more likely congenital bleeding disorder, and then gender. Hemophilia A and B only affects male with exception of X lionization. Whenever word X lionization comes, means lionization is inactivation. So, if in a female 2 X are there, 1 X is inactivated, then it is like 1 X only is working, and in that active 1 X chromosome, if hemophilia gene is defective, then even if one gene only affected, still the patient will be symptomatic. Personal and family history of bleeding disorders, it suggests some congenital bleeding disorder. Then history of challenges such as invasive dental procedure. You will ask whenever any operation was there or any procedure was there or any history of trauma, any history of injections, all these are bleeding challenges which normally happens, and with that actually if prolonged bleeding is there, then we suspect the bleeding disorder. Then menstrual and peripartum bleeding, these also natural bleeding challenges which come across. Then aspirin or other antiplatelet medications can precipitate bleeding, so we should ask in the history. Then we should see for the bleeding score, which type of bleeding, how severe is it, that is suggested by bleeding score. Then clinical features suggestive of cause we should look into, like if jaundice is there, maybe liver disease causing coagulation issues. If splenomegaly, arthropathy, joint and skin laxity, then may be suggestive of Ehlers-Danlos syndrome. If telangiectasia, then maybe it is sign of hereditary hemorrhagic telangiectasia. We should also see sign of anemia, because bleeding may cause anemia. Anatomic lesions we should see, which may lead to actually bleeding because of these lesions. Then gynecological examination if menorrhagia is there. Bleeding disorder, platelet and clotting factor deficiency, these can be actually differentiated clinically कि बच्चे को लग क्या रहा है, मतलब हमें प्लेटलेट वाला प्रॉब्लम लग रहा है या क्लोटिंग फैक्टर वाला. सो इफ म्यूकोक्यूटेनियस ब्लीडिंग, then it suggests platelet defect. If deep soft tissue bleeding like joint and muscles, then it suggests clotting factor deficiency. If bleeding with minor cuts or even after cannulation, it suggests platelet defect, and in clotting factor usually with minor cuts bleeding may not be there. Then if fatigue is present, then it suggests platelet defect, this is very typical, and if absent, then it suggests clotting factor deficiency. Ecchymosis can be there in both, but in platelet defect usually smaller and superficial ecchymosis, and in clotting factor deficiency larger and palpable ecchymosis, sometimes like hematoma. Then hemarthrosis, muscle hematomas are common in clotting factor deficiency. and bleeding after surgery is immediate and mild in case of platelet defect, and it is delayed and severe in case of clotting factor deficiency. So what are these? देखा है कभी कोई पेशेंट ऐसा? Pateki and purpura both. So pateki is pinpoint. Typically word used for pateki is pinpoint, है ना? Pateki less than 3 mm and purpura 3 to 10 mm. More than 10 mm are not purpura. So what is this? पटेकी है, परपिरा है, कुछ बोल रहे परपिरा है, और बोलो इकाइमोसिस. ओके, मैं कह रहा हूँ ये ब्रूज है. सो व्हाट इज द डिफरेंस? सो इकाइमोसिस मोर देन 10 mm, ब्रूज इज सेम बट विद ट्रॉमा. ओके, विद सम लाइक किसी ने थप्पड़ मारा तो वो ब्रूज होगा, इकाइमोसिस नहीं बोलेंगे उसको. इकाइमोसिस ही है एक तरह का, बट कॉज इज ट्रॉमा, देन इट इज ब्रूज. एंड हेमेटोमा नोडुलर एंड not in skin, it is subcutaneous. What is this? This is joint swelling, okay, and other one is joint deformity on this side. So joint swelling, which is suggestive of hemophilia, and joint deformity after repeated bleeding in the same joint, then it will develop into hemophilic arthropathy. Screening, CBC, iron deficiency anemia we should see in that, and because of repeated blood loss also iron deficiency will be there in bleeding disorders. Platelet count we should see, platelet size we should see. If it is big, then maybe it is suggestive of Bernard-Soulier syndrome. So B for B, big platelets in Bernard-Soulier syndrome. PS, other causes like leukemia or any other causes which we can make out in the PS, we should see PS accordingly. And bleeding time is not reliable in pediatrics, but maybe and maybe normal in von Willebrand disease type 2 and 1, but still bleeding time is important for screening because it is a simple bedside test and can be used to suspect, though it will not rule out, but it can be used to suspect some functional platelet disorder, because platelet count will be normal in that case, but bleeding time will be prolonged, and in von Willebrand disease also it will be prolonged, but except this type 2 and some type of type 1. PFA is platelet function analyzer. This is a separate machine with 71 to 97% sensitivity used for platelet function screen. Then APTT and PT. So in PT and APTT we should do next. So in APTT, if prolonged only, it is prolonged only if von Willebrand factor is less than 35% and factor 8 and 9 levels less than 20 to 40%. Then actually PT is for which pathway? Prothrombin time is for which pathway? Anyway, these will come, okay, we will discuss later. So initial von Willebrand factor SS also can be done at first visit. So these investigations actually can be done at first visit also, but there is a systematic approach for bleeding disorder. History and physical examination, which is suggestive of congenital bleeding disorder. Then we should do hemostatic screen. CBC and PS. PS will suggest the platelet size and clumps. If clumps are there, then platelet count may be counted low by the machine, because if 4 platelets clump together, then it will be counted as 1 by the machine. So it may be the sign of spurious thrombocytopenia, and platelets are functioning, that's why they have made the clumps. So the clump suggests that, and platelet size, if it is more, then it suggests that there is more production of the platelet inside the bone marrow. Then bleeding time, PT, APDT, thrombin time, clot retraction, factor 13, von Willebrand factor level, von Willebrand factor activity, euglobulin clot lysis time and blood group. All these should be included in the screen. Screen means we should not miss any bleeding disorder. That's why these other tests also they are down, because alone BT, PT, APDT may miss some cases. Those cases actually will be included in other tests. So, clinical and lab evaluation suggestive of primary hemostatic problem. Primary means related to platelet and von Willebrand factor and vessel wall, and secondary hemostatic problem, it is related to von Willebrand factor and other coagulation factors. So, if clinical and lab evaluation suggests primary hemostatic problem, then we should see whether platelet count is low or not. If it is low, then thrombocytopenia, and which may have different causes: peripheral destruction and decreased production. And if peripheral destruction, then you will see large platelets and adequate megakaryocyte in the marrow, and the reason may be immune or non-immune. In immune, alloimmune or autoimmune. Alloimmune means the antigen is from somebody else, and that antigen entered in our body, and then that our body made some antibody against that antigen. So, it is allo antibody. And autoimmune means antibody is made by our own body against our own antigen and cross reacting with the platelet. Then non-immune cause of destruction is spleen, hypersplenism and hemangioma. Like in spleen destruction is there, similarly in hemangioma also platelet destruction and consumption will be there. That is called as Kasbek-Merritt syndrome. Decreased production acquired because of infection or drugs. Inherited decreased production is divided into 3 groups based on platelet size. If platelet size is normal, then suspect CAMT and TAR. TAR is CAMT is congenital A megakaryocytic thrombocytopenia, and TAR is, what is TAR? TAR syndrome. Have you seen some anomaly, hand anomalies? Initially it is typically associated with thalidomide also. Okay. Thrombocytopenia with absent radius. Okay. So, radius is absent in this. So, a typical hand anomaly will be there. But thrombocytopenia initially is more severe, but with age the thrombocytopenia severity will decrease. Small platelets in case of Wiskott-Eldridge syndrome, it is X-linked recessive disorder found in mainly male with atopic dermatitis, thrombocytopenia and immunodeficiency. Then large platelets in case of Bernard-Sollier syndrome, MYH9 abnormality and Harris platelet syndrome. Harris platelet syndrome is actually normal thing in northeast people. Many of the blood donors have found to have large platelets and thrombocytopenia without any symptom. So, it is normally found in many of the northeast people, especially Assam, West Bengal. Then platelet counts normal, then think of platelet function problem, and for that we need to do platelet aggregometry, which is not available in many of the places, even in Bhopal. Factor 8 levels and von Willebrand factor level we should do. Secondary hemostatic problem, rule out sampling error or heparin effect, do mixing with normal plasma if corrected or not corrected. If corrected, then there is a factor deficiency. If not corrected, then inhibitors or antibodies may be there. So, if factor deficiency, then we should do correction with further correction with aged serum and adsorbed serum. ओके इसको थोड़ा सा समझ लीजिए, आता है किसी को ये मिक्सिंग का प्रिंसिपल? एनीबॉडी? नहीं? ओके। तो नॉर्मल प्लाज्मा में कौन कौन से फैक्टर डेफिशिएंट है? कोई भी नहीं? सब फैक्टर होंगे ना नॉर्मल प्लाज्मा में। और जो पेशेंट का प्लाज्मा है, सपोज उसमें हीमोफीलिया का पेशेंट है, ए फैक्टर 8 कम होगा, ठीक है। अब दोनों को मिक्स कर दिया तो इसमें फैक्टर 8 है, इसमें नहीं है, दोनों को मिक्स कर दिया तो इसकी कमी इसने पूरी कर दी, तो हो गया करेक्शन। तो इसलिए इधर करेक्शन हो रहा है। फैक्टर डेफिशिएंसी में कोई भी फैक्टर की कमी होगा तो वो करेक्ट कर लेगा। क्लियर है ना? तो उसमें एपिडिटी रिपीट करेंगे हम करेक्ट करने के बाद में, तो वो करेक्ट हो गया। अब ये क्या बोला है? एज सीरम और एब्जॉर्ब सीरम। एज सीरम मतलब सिंपल एज मतलब टाइम के साथ में उसको उम्र उसका बढ़ रहा है, तो कितना एज? 24 आवर और 37 डिग्री सेंटीग्रेड जो बॉडी का टेम्परेचर होता है उसी पे रखेंगे। तो 37 डिग्री सेंटीग्रेड पे 24 आवर अगर हमने सीरम को रखा तो वो एज सीरम हो गया। तो उसमें कौन से फैक्टर कम हो जाएंगे टाइम के साथ में? जो लेवाइल फैक्टर होंगे जिनका हाफ लाइफ कम होगा वो ख़त्म हो जाएंगे। तो कौन कौन से जो शॉर्टेस्ट हाफ लाइफ वाले फैक्टर हैं बोलिए? 5 और 8। तो 5 और 8 की उसमें कमी हो जाएगी, ठीक है। अब मान लो ये हीमोफीलिया का पेशेंट का सैंपल है, उसमें 8 कम है, एज सीरम है उसमें भी 8 कम है, ठीक है। दोनों को मिक्स किया तो 8 की कमी पूरी हुई क्या? नहीं हुई, तो वो 8 की कमी तो रहेगी। तो फिर से हम एपिडिटी उस सैंपल में मिक्स करने के बाद में करेंगे तो क्या आएगा? प्रोलॉन्ग आएगा, एबनॉर्मल आएगा, ठीक है ना। तो इसका मतलब करेक्शन नहीं हुआ, एज सीरम से करेक्शन नहीं हुआ। यहाँ क्या लिखा है? नॉट करेक्टेड विद एज सीरम, फैक्टर 5 और 8 डेफिशिएंसी। क्लियर? ठीक है। अब फैक्टर 5 की कमी से ब्लीडिंग होती है क्या? नहीं होती है। तो अगर ये इस स्टेप पे हम आ गए हैं तो ये हीमोफीलिया ए ही है। फिर फैक्टर 8 का लेवल करो और कंफर्म करो, ठीक है। अब एड्जॉर्ब सीरम क्या होता है? एड्जॉर्ब सीरम में सीरम को जो बेरियम हाइड्रोक्साइड कॉलम है उसके थ्रू पास आउट करते हैं। तो बेरियम हाइड्रोक्साइड एक्चुअली विल एड्जॉर्ब द विटामिन के डिपेंडेंट फैक्टर्स। सो व्हाट आर द विटामिन के डिपेंडेंट फैक्टर्स? एनीबॉडी? बोलो खड़े होके। ओके, लिखा है ना 2, 7, 9, 10। कैसे याद रखना है? 2 + 7 = 9 और 10। ओके, 2 + 7 = 9 और 10। सो ये उसमें कम हो जाते हैं। अब ये हीमोफीलिया ए का पेशेंट का है मान लो, और इसमें एड्जॉर्ब सीरम है, तो 2, 7, 9, 10 कम है उसमें, लेकिन 8 तो कम नहीं है, ठीक है। तो इनको मिक्स करेंगे तो क्या होगा? करेक्शन हो जाएगा कि नहीं होगा? हो जाएगा, क्योंकि 8 इसमें है, उसने इसको करेक्ट कर दिया, तो उसमें करेक्शन हो जाएगा एड्जॉर्ब सीरम से, अगर ये हीमोफीलिया ए है तो। लेकिन नॉट करेक्टेड विद एड्जॉर्ब सीरम तो उसमें 2, 7, 9, 10 इनमें से किसी का भी कमी हो सकता है। तो अब हमको देखना है कि वो क्लिनिकली क्या ब्लीडिंग किस तरह का लग रहा है। अगर ये 2 होगा तो कॉमन पाथवे इन्वॉल्वमेंट होगा, 7 होगा तो एक्सटर्नल होगा, और 9 होगा तो ये हो सकता है, मतलब एपीटी प्रोलोंगेशन ये करेगा, और 10 होगा तो भी कॉमन पाथवे होगा। तो अगर केवल एपीटी प्रोलोंग है तो ये 9 वाला ही होना चाहिए, और वही कॉमन है हीमोफीलिया बी, ठीक है। तो फिर उसमें फैक्टर 9 का लेवल करके देख सकते हैं। तो इस तरह से हम मिक्सिंग करते हैं। और भी कर सकते हैं, हम कोई हीमोफीलिया ए का पेशेंट है, उसका सीरम लिया तो अपने आप फैक्टर 8 डेफिशिएंट सीरम आ गया हमारे पास, फिर उसमें मिक्सिंग करो, पता लग जाएगा फैक्टर 8 इसमें है कि नहीं है। एक स्टेप में और मिक्सिंग की जा सकती है। तो इस तरह से हम मिक्सिंग स्टडी कर करके उसको डायग्नोस कर सकते हैं। क्लियर है ना इसमें? अच्छा, अब करेक्शन मान लो नहीं हुआ, ठीक है ना, नॉर्मल प्लाज्मा से सब कुछ है, सारे फैक्टर है, तो भी वो करेक्ट नहीं कर पाया एपीडीटी को। इसका मतलब कि जो पेशेंट के अंदर है एंटीबॉडीज या इनहिबिटर्स है, जो कि इसमें जो भी फैक्टर है उनको भी वो इनएक्टिवेट कर रहा है, ठीक है ना। तो वो इसमें सेकंड स्टेप में आ रहा है। करेक्शन इनिशियली बट नॉट एट 2 hours इंक्यूबेशन, देन डू DRVVT टेस्ट फॉर लूपस एंटीकोएगुलेंट। glucose anticoagulant is an antibody. And if not time and temperature dependent, then inhibitor and factor level we can do, and if DRVVT is negative, then also inhibitor and factor level we can do. Okay. So, we will not go in detail of, we already discussed all these, ये तो सबकी बुक्स में है, ठीक है ना, इंट्रिंसिक और एक्सट्रिंसिक पाथवे एंड देन कॉमन पाथ. So, APTT for intrinsic, PT for extrinsic and TT for कॉमन पाथवे. एक और होता है रेप्लेट्स टाइम, जो थ्योरेटिकल है, कहीं भी टेस्ट ये अवेलेबल नहीं है, वो हिपेरिन कॉन्टामिनेशन को डिटेक्ट करने के लिए. तो बेसिक प्रिंसिपल जो मैंने आपको समझाया वो है ना. एक केस का अपन डायग्नोस्टिक वर्कअप इवेल्युएट करते हैं. जैसे एपिडिटी इज 56 सेकंड, हाफ पेशेंट हाफ कंट्रोल प्लाज्मा, इट इज नाउ 33.5 सेकंड. इसका मतलब क्या है, फैक्टर डेफिशिएंसी है या इनहिबिटर से. APTT is corrected after mixing with plasma. अरे बोलो, करेक्ट हो गया. थोड़ा टाइम चाहिए ना, इतना रिफ्लेक्सली नहीं आता है. बोलो, आप बोलो. हाँ, करेक्टेड तो क्या इंडिकेट कर रहा है, फैक्टर डेफिशिएंसी है या एंटीबॉडीज है. फैक्टर डेफिशिएंसी, वेरी गुड. तो फिर एड्जॉर्ब्स प्लाज्मा के साथ भी करेक्टेड है. इसका क्या मतलब है, करेक्ट है ना. 9 का भी डेफिशिएंसी होता तो करेक्ट नहीं होता. फिर एस सीरम के साथ में करेक्ट नहीं हुआ, पार्शियली थोड़ा बहुत हुआ बट नहीं हुआ, तो फैक्टर 8 डेफिशिएंसी की तरफ जा रहा है. देन फैक्टर 8 इज 2.1%. तो डायग्नोसिस क्या है इसका, ये नहीं कह सकते. फैक्टर 8 डेफिशिएंसी है बस. हीमोफीलिया ए है या नहीं है, क्या फैक्टर 8 डेफिशिएंसी किसी और में भी हो सकती है नॉन हीमोफीलिया में, ये देखना पड़ेगा. ठीक है. तो ये हीमोफीलिया हो सकता है, लेकिन इतना सीवियर नहीं है, मॉडरेट है, तो हमें वॉन ब्रांड डिजीज़ के लिए भी देखना चाहिए. VWF लेवल करना चाहिए. अगर वो कम है तो फैक्टर 8 डेफिशिएंसी उसके साथ भी हो सकती है, बिकॉज बोथ गोज टुगेदर. वॉन ब्रांड फैक्टर एक्चुअली इंक्रीजेज द हाफ लाइफ ऑफ फैक्टर 8. अगर वो कम होगा तो फैक्टर 8 भी कम होगा. तो ये ज़रूर देखना चाहिए. और स्पेशली अगर फीमेल में ये रिपोर्ट है तब तो आपको देखना ही पड़ेगा, क्योंकि हीमोफीलिया इज वेरी रेयर इन फीमेल्स. सो हीमोफीलिया is love of bleeding. The word hemophilia means love of bleeding. So, it is X-linked recessive hereditary disorder that is due to defective or deficient factor 8. It is the second most inherited clotting factor abnormality after von Willebrand disease, which is most common. 1 in 5,000 to 10,000 live male births. No difference between racial groups. So, genetics, it is X-linked recessive. So, if father is normal and here mother is having carrier, then child may be affected, and some female may be carrier, some may be normal. Okay. So, if this child is affected and this becomes father, okay, then what are the chances when the spouse is normal, then what are the chances of children having hemophilia? Nil, because this will give only Y chromosome to males. So, it is X linked, not Y linked. So, it will not go in next generation of males, but in females it will go definitely, because one X is defective and that one X will go in all females. So, all females will be carrier. Okay. So, अगर पिताजी को हीमोफीलिया ए है तो कोई भी बच्चे को हीमोफीलिया ए नहीं होगा बस, लेकिन सारी फीमेल कैरियर होगी, उनके बच्चों को फिर होगा। तो ये फीमेल कैरियर है तो इनके बच्चों को फिर कोई कुछ भी हो सकता है, नॉर्मल भी हो सकते हैं, और ये मेल है तो उसमें नॉर्मल मेल भी हो सकता है और अफेक्टेड मेल भी हो सकता है, और फीमेल कैरियर भी हो सकती है, नॉर्मल भी हो सकती है। So, can female have hemophilia? In case of X lionization and Turner syndrome, it is possible to have hemophilia. If a carrier female mates with the affected male, half their daughters are at risk of homozygous. ठीक है ना, जैसे इसमें ये फीमेल अगर कैरियर होती, ओके, देन एक डिफेक्टिव एक्स इधर से आया, एक डिफेक्टिव एक्स इधर से आया, तो दोनों एक्स में प्रॉब्लम होगा तो हीमोफीलिया फीमेल को भी हो सकता है। Clinical manifestation depend on severity. If severe, which is less than 1% factor activity, then spontaneous hemorrhages from early infancy, frequent spontaneous hemarthrosis may be there, and for moderate 2 to 5% hemorrhages secondary to trauma or surgery, occasionally spontaneous hemarthrosis. For mild, more than 5% level hemorrhage secondary to trauma or surgery, rarely spontaneous bleeding. Okay. So, in mild cases also spontaneous bleeding is possible, but rare. So, co-inheritance of prothrombotic mutations like factor V laden can decrease the risk of bleeding. The most common, painful and most physically, economically and psychologically debilitating disease. Clinically, when hemarthrosis is there, then there is sense of aura, tingling, warm sensation inside the joint patient will feel when blood is like moving inside the joint. So, that time if we give factor VIII, that is the best time where we can actually stop the bleeding immediately, but it is very rare for them to receive factor VIII at that time of aura, unless the child is in hospital only or factor is available at home and somebody is there to give. So, then child will have excruciating pain because of the stretching of the joint, and generally one joint at a time, most commonly knee, then elbow, then wrist and then ankles, and edema, erythema, warmth and loss, lack of movements, loss of movement in that joint may be there. If treated early, it can subside in 6 to 8 hours and disappear in 12 to 24 hours. Pathophysiology, bleeding in synovial space, then incomplete reabsorption of this blood leading to chronic proliferative synovitis, that blood will irritate the synovial membrane and the inflammation will be there. Synovium more thickened and vascular, leading to recurrence of bleeding in the same joint with minor trauma or even spontaneously, and creating a target joint. So, that joint become a target joint where at risk of again bleeding, and because of bleeding again inflammation, again neovascularization, again fragile vessels and again bleeding. So, in that vicious cycle child will be there. Destruction of surrounding structures will lead to bones necrosis and cyst formation and osteophytes, leading to chronic hemophilic arthropathy. Finally, the joint will have fibrous and then bony ankylosis, and that time it will be like silent joint and there will not be any movement and there will not be any hemarthrosis further. So, hematomas, especially muscle hematoma like SOS hematoma, gastrocnemius hematoma, these are very common. Subcutaneous bleeding may be there, muscle hematoma, intracranial bleeding may be there. So, if any headache in a child with hemophilia, we should suspect intracranial bleeding, give factor first and then send for CT scan to confirm. Other clinical manifestation, gastrointestinal bleeding, mucosal bleeding, genitourinary bleeding like hematuria. Laboratory diagnosis, we already discussed CBC, APDT will be prolonged and normal PT and bleeding time, and mixing we will do, then factor level we will do. Carrier detection and antenatal diagnosis. Family history, if we follow the inheritance pattern, a female is a carrier if she has a hemophilic father, has two hemophilic sons, one hemophilic son and has a family history, has a son affected but no family history, there is a 67% chances that she is carrier. Carrier detection and antenatal diagnosis. For prenatal diagnosis, DNA testing or chorionic villus sample obtained by biopsy at week 12. Then treatment, general considerations are avoidance of aspirin and NSAID, no IM injections, and counseling for the patient and family, how to prevent the further bleeding and how to take care. Then blood products, we can give FFP or cryoprecipitate, which is stored at minus 20 degree centigrade, shelf life is 1 year, and group match we can give, no need like cross match, not absolutely needed, but can be done for contaminant RBCs. Time needed for issue half to 1 hour for thawing because it is a frozen thing, and transfusion rate is within 1 hour we should give the whole dose. So, FFP comes in 200 ml, dose is 10 to 15 ml per kg, and it contains all the factors. In undiagnosed patient also we can give, but we should take all the possible sample for diagnosis before giving any transfusion. Cryoprecipitate 15 to 30 ml it comes, it contains fibrinogen, factor 8, factor 13 and Wolfram factor. Okay. So, in that all the factors it contains first, last and middle. Fibrinogen, last is factor 13 and middle is factor 8, and with factor 8 von Brand factor. So, these are the content of cryoprecipitate. So, cryoprecipitate does not contain everything, all factors, no. So, if factor 9 deficiency is there, you can't give cryoprecipitate. Remember, if factor 9 deficiency, hemophilia B, you can't give cryoprecipitate. Only option for blood is FFP. So, 1 bag per 5 to 10 kg is the dose for neonate, 1 to 3 ml per kg plus 7 ml for tubing. Then factor replacement. So, treatment of choice is factor replacement, not the blood, because blood will have their own disadvantages. Replacement of factor 8 is the cardinal step to prevent or reverse acute bleeding episode. Dosing, replacement product can be given on the basis of body weight or plasma volume. Approximately 5% of the body weight is the plasma volume. 1 unit per ml is equal to 100% factor activity. So, practically 1 unit of factor 8 per kg if we give, then it increases factor 8 about 0.02 unit per ml. In a severe hemophilic, to raise factor 8 to 100% activity or 1 unit per ml concentration, we need 50 unit per kg. So, redosing is based on half life, 8 to 12 hours in case of factor 8, and usually factor 8 is given BD to TDS, but factor 9 is given OD to BD, because factor 9 half life is more. Then plasma derived or recombinant, both type of factors are there, both has their own advantages and disadvantages, but equally effective. So, whatever available we should give, but if von Brand factor is less, then we should give plasma derived only, because plasma derived factor 8 will contain von Brand factor as a impurity. So, intermediate purity plasma derived factor 8 should be given for von Brand disease patients, but recombinant factor 8 we can't give, because they will have only factor 8, not von Brand factor. Okay. So, in short we should remember that 50 unit per kg is the dose for 100% activity. Now, target level for different bleeding. So, if mild bleeding, then less factor 8 target is needed, but if severe bleeding like retroperitoneal bleed, retropharyngeal bleed, CNS bleed, hematuria, then we need up to 100% of level here. Otherwise, 30 to 50 in most of the cases we need. So, duration depends on the risk of bleeding. Okay. So, like hemarthrosis, after some time it will stop. So, 1 to 2 days we can give, or if repeated bleeding target joint is there, we can actually give for some 4 to 6 weeks till the everything, all synovitis settles in the target joint. And if hematoma, 1 to 2 days, if GI bleeding, then till mucosal recovery. When mucosa, once mucosa has come, then we do not need. So, mucosa comes after like 3 days, so 3 to 7 days, so we need around 7 days. Otherwise, if we do not cover properly, then rebleed will be there again and again, okay, from the same site. So, better to have replacement till mucosa recovers. Then epistaxis until it is resolved, oral mucosa until resolved, hematuria until resolved, but CNS bleed, retroperitoneal and retropharyngeal, we need at least 7 to 10 days of replacement. Otherwise, rebleed will be there, and rebleed may be life threatening in these situations. So, what are the local treatment or non-factor therapy we can give? One is fibrin glue. It contains fibrinogen, thrombin and factor 13. It is placed in the site of injury and stabilizes the clot, used in dental procedures and after circumcision. Antifibrinolytic agents, epsilon aminocaproic acid or tranexamic acid. Epsilon aminocaproic acid is not available in India, and tranexamic acid is not available in America. They have epsilon aminocaproic acid. So, we use tranexamic acid. The dose is 25 mg per kg per dose 3 times a day. So, how it works? There are actually fibrinolytic components in the wet secretions from the body, like saliva and mucus secretion in the GIT. So, if bleeding is there in these places, fibrinolysis will happen to reform the clot, and if clot is not stable, the clot actually will dissolve and rebleed will be there. So, to decrease the chances of that rebleed, we want to inhibit the fibrinolysis. So, that is why we give antifibrinolytic agents. So, tranexamic acid will stop the dissolution of the clot already formed in the oral cavity. But if there is no secretions, wet secretions, it will not work. Okay. Like skin bleed is there, there is no secretion or fibrinolysis happening here, it will not work here. So, we should not use in every bleeding, okay, only wet bleeding like epistaxis and oral bleed, oral nasal bleed or GI bleed, in that we can use. But in urine bleed, it is mucosal bleed, but we should not use. Why? It is contraindicated in urinary bleeding, because if any clot is formed, we want urinary tract to be clear of that clot, otherwise urinary tract will be obstructed. Okay. A child will come in emergency for urinary retention if there is a clot. So, clot should dissolve, we can't inhibit dissolution of clot in urinary tract, that is why it is contraindicated in urinary bleeding. Now, desmopressin actually lead to increase in factor 8 levels in patient with mild hemophilia 2 to 4 times above baseline. The mechanism is release of factor 8 and 1 Wildron factor from endothelial storage sites. Has spared many hemophilics of blood-borne products in 1970s. Repeated administration result in diminished response because of tachyphylaxis. Side effects are hyponatremia, facial flushing and headache. So, basically for some time we can use it, not regularly. Course and prognosis. Replacement therapy has its complications, which include development of factor VIII antibodies. Repeatedly we give factor VIII, then body will make antibodies against factor VIII. Those are called as inhibitors. Liver disease resulting from hepatitis B and C. Plasma derived factor VIII also may have some hepatitis or viral component, and that also may actually lead to viral infections, may spread like blood component says, but recombinant factor VIII will not have this risk. Infection with HIV. Inhibitor monitoring 3 to 6 monthly in children before surgery or invasive procedures, because we want to make sure that our factor will work. Once we have cut during surgery and then factor is not working because of inhibitors, then we will be in trouble. So, better to test before any procedure. Unexpectedly poor response to factor VIII. Factor VIII is not working, then we should think of inhibitors. Inhibitors are the level is reported as in the Bethesda assay. If less than 5 BU Bethesda units, then low responders. If more than 5 BU, then high responders. In that also there will be low titer and high titer in high responders also. Management of inhibitors. Define inhibitor titer. Low titer eradicated by ITI. ITI is immune tolerance inhibition. So, if we give lower dose initially and then slowly increase the dose, then it will lead to immune tolerance inhibition. So, then the factor will start working. Okay, initial doses actually will neutralize the antibodies. And in case of high titer, there are options which are called as bypassing agent. These are factor VIII bypassing agent, which will lead to clotting, which participate in clotting without factor VIII in the body. So, these are recombinant factor 7A, activated factor 7, which is called as comes as Novo 7 brand name. This activates external extrinsic pathway, and that is how the clotting will happen, and 90 to 120 microgram per kg is the dose, and duration is only 2 hours. It works only for 2 hours, and the cost is about 40-50,000. So, it is very costly actually. Every 2 hours we have to use again. So, for one time we can use to stop bleeding, but to maintain it very difficult. Then APCC, this one prothrombin complex concentrate, 50 to 100 international unit per kg. It works with immunoadsorption, antibodies will be adsorbed on that. And low titer, then if non life threatening bleeding with low titer, then we can use high dose factor 8 or factor 9, 150 to 200 IU per kg per dose, that is very high dose. So, we think the concept is the in high dose some factor will be utilized in neutralizing the antibodies, and some factors will actually work. And if life threatening bleed, then high dose factor 8, factor 7A, APCC or PCC can be used, bypassing agent can be used. Management of inhibitors in hemophilia B, use bypassing agents factor 7, APCC and PCC. Management of acquired hemophilia, minor bleed DDAVP or factor 8, and major bleed porcine factor 8, bypassing agent, plasmapheresis, immunomodulators, because in acquired hemophilia there are antibodies. So, to decrease the production of those antibodies against factors, we can use immunosuppressives. Newer therapies, non-factor therapies are coming up now. Extended half life factor 8 or 9, where it is pegylated or Fc protein to decrease the clearance and increase the T half, and given doses every 1 to 14 days instead of 3 times a day, 2 times a day or OD, it is every 14 days also it doses comes because of extended half life. then factor 8 mimemics. So, these are like act like factor 8, but actually not factor 8. So, the most important agent which is commonly used now, it is available in India and sometimes free also, Emicizumab. It is monoclonal humanized bispecific antibody. It replaces the function of factor 8 by bridging activated factor 9 and factor 10. Weekly subcutaneous injection is given, but it is not cost effective because as compared to factor 8 as of now, but it is available and cost is decreasing year by year. Anti tissue factor pathway inhibitor TFPI antibody Concizumab, then Fitusiran, this is also launched in India now, it is available. RNI therapeutic targeting antithrombin, then gene therapy is still under trial. Then ITP, something about ITP. ITP full form, initially it was idiopathic thrombocytopenic purpura. Still I think in your UG book it is idiopathic thrombocytopenic purpura, but that term is gone 20 years back. So, now the term is immune thrombocytopenia. Why purpura is removed? Because purpura is not always the manifestation. Why idiopathic removed? Because we know the etiology, it is immune. Okay. So, immune thrombocytopenia. The causes of thrombocytopenia we won't go in detail. So, there are terminologies you should remember. The platelet threshold used for thrombocytopenia in this setting ITP is 1 lakh, not 1.5 lakh, which is a normal range cutoff. Then primary ITP, absence of any secondary cause of thrombocytopenia by exclusion. So, diagnosis of ITP is by exclusion. So, we have to do proper history, physical examination, CBC, peripheral smear to rule out all other causes. Then secondary ITP means there is some cause, either some disease or some drug exposure, some immunodeficiency also causes ITP. So, then it is not actually ITP, it is secondary thrombocytopenia. Then severe ITP, bleeding needing treatment regardless of the platelet count, then it is a severe ITP. Then newly diagnosed up to 3 months, persistent 3 to 12 months, chronic more than 12 months. So, this is the timeline. Okay. So, in initial books, if you read old books or if some books has mistakenly taken the same timeline, then chronic is defined as 6 months, but not 6 months, nowadays it is 12 months. This is also 20-year-old change. Then steroid dependent ITP means once we decrease the steroid dose, again the thrombocytopenia starts. So, and then we increase the dose, again it is responded. Complete response means more than 1 lakh platelet with no bleeding. Response is defined as more than 30,000 platelet and plus at least 2-fold increase from the baseline and no bleeding, then it is response, not complete, but response is there. No response if less than 30 or less than 2-fold increase or bleeding, any one of these. Refractory ITP, failure to achieve at least R means response or loss of R after loss of response after splenectomy plus need for treatment to control the bleeding. Okay, splenectomy कर लिया तो भी वो उसको है, response नहीं है, उसको loss हो गया है, यहाँ response आया ही नहीं. Okay, then it is refractory. तो pathophysiology basically immune and there is component of decreased production also in this. So, clinically it is the ITP is ITP patient will be otherwise well, playful, well, there is no fever, nothing, no other problem, only those spots will be there or some bleeding may be there, some mucosal bleeding may be there. तो टैनी मल्टीपल पटिक्यूल स्पॉट्स, पटिकी को कैसे आइडेंटिफाई करते हैं हमने जैसे फोटो देखा था, मॉस्किटो बाइट और पटिकी में डिफरेंस करना आना चाहिए आपको। तो मॉस्किटो बाइट में एक्चुअली वेस्कुलर डायलेटेशन होता है, तो आप अगर ब्लेंच करोगे तो ब्लेंच हो जाएंगे, बट पटिकी ब्लेंच नहीं होंगे, वो ब्लीडिंग है जो बाहर आ गई है और डिस्प्लेस नहीं होगी प्रेशर से, तो ये ध्यान रखना है ना। बाकी वो पटिकी का आपने फोटो देखा था वैसा ही है। हिस्ट्री ऑफ रिसेंट वायरल इलनेसेस एंड डायग्नोसिस ऑफ exclusion. Pateki, bruising, bleeding gum, melena, epistaxis are commonly seen, and it is important to differentiate between mucous membrane and cutaneous bleeding, as these relate to severity of bleeding. If wet bleeding means mucous membrane bleeding, then it is severe. Patient presenting with mucous membrane bleeding more likely to require medical intervention. Older age at diagnosis associated with more severe bleeding and chronic course, and more chances of secondary causes also in adolescent or adult. Atypical features means any feature is there, then don't think that it is straightforward ITP, there may be something else, so you have to do bone marrow or something to rule out other causes. At a very young age, relatively rare, under 2 years. Family history of thrombocytopenia or bleeding, then congenital causes may be there. Significant lymphadenopathy, hepatosplenomegaly, anemia disproportionate to the degree of bleeding, leukocytosis, leukopenia, deranged clotting screen, or systemically unwell child. मतलब कोई भी प्रॉब्लम है एक्चुअली, थ्रोम्बोसाइटोपिनिया एंड स्किन ब्लीड एंड म्यूकस ब्लीड, इसके अलावा कोई भी दूसरा प्रॉब्लम, चाहे वो लेबोरेटरी में हो, चाहे फिजिकल एग्जामिनेशन पे हो, चाहे हिस्ट्री में हो, वो एटिपिकल है, वो टिपिकल आईटीपी नहीं है, देन नीड्स इवैल्यूएशन. सो बोन मेरो करना है नहीं करना, एनी एटिपिकल फीचर्स है तो करना है. अगर आपको भरोसा नहीं है लेबोरेटरी वाले पे कि उसने पीएस देखा कि नहीं देखा है ना, प्राइवेट में हम सीबीसी भेजेंगे, पीएस भेजेंगे, कोई भी कुछ भी आपको रिपोर्ट करके दे देगा, ओके सही से नहीं किया है. यहाँ इवन इंस्टीट्यूशनल भी आपको अगर भरोसा नहीं है तो आप बात कीजिए, आपको लग रहा है कि यहाँ नहीं सही से देखा है तो फिर आप बोन मेरो की तरफ जा सकते हैं, बट पहले डिस्कशन होना चाहिए. टिपिकल आईटीपी डोंट नीड बोन मेरो एग्जामिनेशन. रेड फ्लैग्स, एक्टिव ब्लीडिंग फ्रॉम एनी साइट, एंड अगर एक्टिव ब्लीडिंग है तो इसका मतलब कहीं से भी और भी इंटरनल ब्लीड भी हो सकता है. ICH, इंट्राक्रैनियल हेमरेज, chances less than 1%, but it is more common in children with hematuria plus head trauma plus platelet count less than 10,000, which increases the risk of intracranial bleeding. क्योंकि internal bleeding are more problematic, like abdominal bleeding or intracranial bleeding. So if we can find out the risk factors, then we can actually more likely to treat those patients. Management goal is to achieve a safe platelet count to maintain hemostasis. Wait and watch policy for platelet count less than 1 lakh and no wet bleeds. Okay, only skin bleed and less than 1 lakh count, nothing to do. The decision to treat should not be based solely on platelet count and must take into account the severity of bleeding and associated risk factors. Avoid use of NSAIDs and IM injections. तो क्या क्या ऑप्शन है ट्रीटमेंट के लिए? वेट एंड वॉच, टाइम टू रेस्पॉन्स 2 वीक टू 6 मंथ में स्पॉन्टेनियस रिजोल्यूशन हो जाता है अधिकतर, एंड ड्यूरेशन ऑफ रेस्पॉन्स इज लॉन्ग टर्म, एंड रेस्पॉन्स रेट इज 2/3 ऑफ चिल्ड्रन ऑटोमेटिकली. तो क्यों करना है कुछ भी? इफ नो वेट ब्लीड देन यू कैन डू दैट, बट इफ वेट ब्लीड आर देयर देन ट्रीट विथ सम एजेंट. क्या है? तो फर्स्ट लाइन में IVIG, प्रेडनिसोलोन, NTD, ये 3 है, ठीक है. तो IVIG 1 ग्राम पर kg सिंगल डोज, टाइम टू रेस्पॉन्स 48 आवर, ड्यूरेशन 2 to 3 weeks. It will act for 2 to 3 weeks only. If body has not corrected the cause automatically, then again recurrence will be there after 3 weeks. Response rate is 80%. 1/3 of children relapse after 6 weeks. Prednisolone 1 mg per kg per oral for 7 days, taper over 3 weeks, or 4 mg per kg per day for 4 days, or 2 mg per kg per day for 7 days, or 2 mg per kg per day for 5 days. There are different protocols. Basically, nowadays it is treated with short term steroids, not the long term, like continuously for 2-3 weeks we will give and then taper, not like that. Okay. So, pulse steroid only given to decrease the chances of side effects of the steroid. So, time to respond 2 to 7 days, duration of response variable, response rate 75%, consider bone marrow to exclude other causes before steroid, because steroid may act in leukemia also. If you are not evaluated properly and it is leukemia, then leukemia may go in partial remission, and steroid is a very good component of treatment in leukemia, and we will lose that component. It will not act on the remaining population which comes up later on, and diagnosis will be difficult if already steroid is used because of decreased number of blasts. So, never use steroid without ensuring that it is ITP only and not the leukemia. NTD, you can use IVIG if doubt is there, no issues, but it is costly. For about 30 kg child, 1 lakh will be the cost. NTD 50 to 75 unit per kg IV, and it acts little faster and acts little longer than other agents, and response rate is little lesser. And methylpred dexamethasone also can be given. Azathioprine, rituximab, splenectomy, Dapsone, all these for chronic ITP, where the steroid either fails or repeated need of steroid is there, and we do not want to give repeated steroids. Cyclosporin A, MMF, danazole, vincristine, vinblastine, cyclophosphamide, these are also the choice. There is a lot of choice is there, but which will work in which patient nobody knows. We have to try and see, and usually response takes lot of time, means maybe 3 months, 1 month to 3 months it takes. So, unless we give at least 3 month trial, we can't say that it is not effective. So, they have to take regularly before saying that this agent is not working. Do we need platelet transfusion? Only if active bleeding is there. To prevent that, we can give platelet transfusion, otherwise there is no role of platelet transfusion at all in any situation. Splenectomy, it can be used if medical management is not working. Recent advances, rituximab anti-CD20, CD20 is on which cell? B cells, and B cell produces antibodies. So, anti-CD20 means anti-B cell it is. So, it is destroying the B cells. So, once B cell is B cell destruction is there, then antibody production will decrease, and that is how that immunity will go down, and there is risk of infection definitely, but child will be cured of the ITP, but the response rate is around 40 to 60% in chronic ITP. TPO agonist, thrombopoietin receptor agonist. So, these will increase the production of platelet, romiplostin and eltromopeg. Romiplostin is subcutaneous injection and eltromopeg is oral medicine. These are commonly used nowadays. Recombinant factor 7A for hemostasis in life threatening bleed. Here factor 7 deficiency is not there, but we can use recombinant factor 7A to stop the bleeding immediately. Okay. Hinox-Conlin purpura IgA vasculitis, something just 2 slides. Most common systemic vasculitis in children 3 to 15 year of age is usually affected. Immune mediated, triggered by infection or antigen. Tetrad in HSP is palpable purpura without thrombocytopenia and coagulopathy, arthralgia and or arthritis, abdominal pain, renal disease, increase in creatinine, hypertension, proteinuria, these may be there. So, palpable purpura, arthralgia or arthritis, abdominal pain and renal disease. Mostly clinical diagnosis, IgA deposition on skin or kidney biopsy can be documented, and negative autoantibodies like ANA, USG abdomen for other causes of pain abdomen can be done. Urine routine micro should be done. Management: rest, oral hydration, pain management with naproxen. If not responding, systemic steroid can be given. Less than 1% or develop chronic kidney disease, follow up with BP and urine test. So basically treatment is steroid, otherwise supportive only. Thank you very much.